I don't know if you knew, recently received an award for perpetual sartorial elegance, and possibly it was a finalist in the nicest person in Wales category. Ladies and gentlemen, Dr. Singh.
Well, thank you. Thank you, thank you, thank you. What a wonderful day for me to be here today. And this day, get me to know all your views, and I take all the things, steal it away, go back, sit with my Welsh Government colleagues, and start getting everything back to the Fracture Liaison Services Development and Quality Assurance Board. You have made my life really easier. Thank you. So, do I do this? Great. Now, you can see this. So after hearing all these views and plans, and you heard from Cabinet Secretary today that there is a funding and there is money. You heard from the 6 Goals team, why do we need to do it, how much impact it's having on our hospitals' acute setting. And you heard from the Welsh Value colleagues that why it is important to bring it now. But we do need to bring it all this together in a policy. And that's one of the very key job which I will be taking alongside all with you, and I would need your help. And on this note, I'd like to thank the Welsh Government colleagues, particularly on this 6 Goals and Welsh Value team on this. ROS has been extremely helpful in giving us all the guidance. So big thanks to all those patients who have shared their stories. I think we know this. We are an aging nation and we should be proud of that. We need to think, should we get to the successful aging in ourselves? But if you look at this, that above the age of 65, we have grown up by 17% in Wales. But if you look at the orange bar, above the age of 50, majority of patients are growing in Wales. And this is the census from year 2021. But if you come here, another 10 years down the line, you'll only see this figure is getting more older and the population is growing. So no surprises. Now, I think again, it's needless to say, why do we need to change? If we need to think about this, the prevalence of osteoporosis is very high in the UK as compared to other European countries. We are just one of them as right. But we also heard about the cost, how many people are living with this condition, and in Wales, we're expecting 20,000 fragility fractures in a year. That's where we are. So we have to need to do something, and we need a change. But do we need to act fast? And you heard from many speakers today, the risk of refracture. We need to act fast to de-risk that fracture risk, and we have got enough evidence to support that. The fracture risk is fairly high within the 1 to 2 years, and if we do not capture that fracture in the first 2 years, they'll come back to those hospitals again and having more harm. And we are particularly talking of non-hip fractures. And what Anthony was saying about today with the hip fractures, already that happened, and they are just been managing some of our failures, which Anthony described as well. And I accept that as well. We need to act fast. We need to do things differently today. So that takes us to the next part, that do we have enough evidence? And you heard from experts, Professor Stone has clearly mentioned today that how much treatment sequence is there, but every treatment we have in the literature actually do the job. Some do better as compared to others. So it's our role to differentiate from a low risk to a high risk to a very high risk so they get the evidence-based treatment. But that depends on us, and there is enough evidence to support that. What happens if you don't treat? Now that's the journey of an individual from the age 50 onwards up to 90. If you don't treat, so when you see that everything in a blue bar or a blue shade, that's an added comorbidity burden with every fracture. So when a first fracture happened before 60, that's a forearm fracture, the comorbidity burden has added to that individual. With the next fracture, it just goes. They do recover a little bit, but added to have more to that straight away. And it continued to go up by the time they had a hip fracture. But if you look at the individuals which are under that bar, which probably, that's right, which is under that, and it shows they have less comparatively accumulation of comorbidity burden as compared to those who had no fractures. So in other words, that comorbidity burden to some extent is preventable, is avoidable. And we have evidence why not to do that. So this is the most recent trial which when I was discussing with Kasim, do we need to do anything else? But when we know that the treatment is working really well, just go back and treat. And if you don't treat, we'll continue to face the consequences what we have observed now. Now that's the burden of fragility fracture in Wales. So looking at any fracture, whether it's a hip, non-hip in the patient, in the hospitals, or looking at the clinical vertebral fractures or any other fractures, it just costs us. And the cost comes from the acute care, social care, and primary care. So that's the cost we need to keep in our mind when we're developing our policies and looking at where the savings are coming. And these are the type of things which I take it back to the Welsh Government all the time to see that if a savings are having from cross-divisional, we are discussing within the hospital saving, but we have to go outside that. This saving is for Wales. And the saving, if it's coming from the social services or primary care, why not to use that and put that money in a ring-fence basis and suggest that how we run our FLS services. But we do need to have that. It still have got that unmeasurable cost, the qualities, impact of life on individuals. I think we need to have patients' voice at every point with us to see how they are being affected. The patient stories, what we heard from ROS team today, they are very crucial for develop our services. Now, that takes me to the next step, what I've been doing in the last 18 months or so. Since we last stood up here in September 2022, we just managed to get attention from the government. And that has led to this statement in February that we need a coverage. What does coverage mean? Coverage means that we have all health boards on board and including FLS in their IMTP plans, having a clinical leadership there, and started to link with us and saying that yes, we need these services. Yes, we need to appoint clinical nurse specialists who actually take the responsibility and ownership of the services and deliver it. We need to support the administrators. Do we have those ring fence funding agreed or not? That's what the coverage means. And will we be able to achieve that by September 2024? And you heard from CAPSAC and my other colleagues today, we are not too far away. We have got 6 months. We need to crack on with that recruitment now. And if we don't recruit now, when we have got funding, we won't be able to actually justify that we have got the principles met for the FLSDB and all the KPIs achieved. This is one of the really crucial time for us that we get on with this and prove that we can recruit, we can train, we can develop those staff members. Now, that's the database what we had in the last 4 years. And it's here, it's in front of us, and Craig mentioned very clearly that we are identifying 21% in patients in Wales. But I think there is slightly tweaked this FLSDB, that not every health board is actually participating in FLSDB database as we speak, but the services which they're delivering is continue to increasing. The work what orthogeriatrician colleagues are saying is not part of this. I think we are doing better than this, but we have to see where we are with the FLSDB database. But there are other KPIs which we have to improve. So that ongoing continuous quality improvement work has to be factored in our policies. But whatever we identify more. At least we continue to provide that initial treatment. And more importantly, we started to show some improvement in the KPI 9, where we have got 16 weeks follow-up going up in the last few years to 40% in Wales. And I think we need to continue to work more on that. So that's the cost of the FLS in Wales, between 2.5 to 5 million. But it costs us 3 times more if we do not have FLS. Or in other words, effectiveness of FLS is about 11 billion pounds if we have one. So there's no brainer and we have to do that. Yes, we are working at the moment with the 6 health boards very, very actively. And with POVIS, we are actually integrating more to see that how that support can be given from the adjacent health boards, but also to continue to support the primary care model which we have at the moment. I have personally linked with the HQIP and the FLSDB teams to make sure that we get the data, what patients are getting care when they are in from POVIS, and are those patients, when they get treated or picked up by the FLS team, by adjacent health board or NHS trust, has that been communicated to the primary care team or not, so that the ongoing treatment can continue. But that work is in progress. So where we are in Wales, this is the phase 1, what you're hearing today, of a multi-phase project. The phase 1 for us was to get everybody on board, which we have now. 6 Goals team have funded us with the £750,000. These are more details, and Welsh Value has given us money. Now that money is for a year, but we have to prove our case. What we have done with that money, we have put a funding aside to recruit 13 clinical nurse specialists and 11 administrators to support that for the teams. And this has been spread throughout Wales in all the health boards. Now we have a dedicated clinical leads All health boards in Wales are now registered formally with the FLSDP, and hopefully soon they will be starting participating in that, and we'll see the real database. We can use this database as a quality work. So that takes me to put it all together in the model. How does the model look like? The model, I think we have to based on our 3 priorities, which you might have heard last time. The priority 1 remains education and awareness, so that we promote health in Wales and anywhere else. But this health and education is not for the healthcare staff, it includes patients and their families. We need to provide that care, but how? We need to having a very strong integration and partnership, and that remains a very, very strong priority on our list. And the partnership what we had, whether it's a primary care or third sector, it includes everybody. Without that, we won't be able to move forward. And we need to continue to protect patients from having a refracture. And that's the current priority for us in Wales, that we should improve our identification, management, and care. We don't need to reinvent the wheel. I'm using everything what we have there. We're just spreading the message, getting it back to the policymakers and our managers. How do we do that? We need to identify fast. We need to assess that and then provide the person-centered treatment and continue to follow adherence. But within that, we have specifically put the community and primary care, who we need to work with more closely so that the ongoing annual reviews can be done in the community. This is a long-term condition, and people are going to live with this, and it's not going to go away. So we need that. But how are we going to do that? Now, this has been set on the quality triology. The quality triology first is quality planning, having patient involvement and engagement at the center of these services, so that we come to know from the stakeholders and service user exactly what we need to deliver and what we have to do. We have to follow the Welsh standards. For example, we have got a frailty quality statement. We take that factors into this, and when we develop these services, and we should also take the good work which ROS and FAP has given us before we plan these services. This should be continuously monitored and continuously looking for the quality improvement work, what Kasim was mentioning this morning. Without that, we won't be able to say where we are. Followed by that, it's a quality management. And we heard very clearly, had a very clear discussion with Kasim as well. If we are participating, if we are improving, how do we know? We just simply need to think of the FLSDP participation, get the 80-50-80 rule embedded in the system and get it there. But we must not forget that we have to have Welsh value participation, getting the patient outcomes and evaluation measures in practice, and how we follow that. The final part of quality triology remains quality assurance. So we have established our FLS Development and Quality Assurance Board, which people come from every health board, third sector, and widely, where we get the reports every 3 months. That remains one of the key part for us. Getting to 6 goals board and Welsh value team, and taking it to FAP, which we meet every 6 months, remains the key. This all get reported back to the Welsh government, and it does take us to the part that how we develop our model in Wales. So that's the model which we are looking for. And actually I'm very pleased to share today that after hearing from CAPSACT that we can to go ahead with the quality statement, this all can be translated into a quality statement. So the part of the quality statement also have to include how we're going to deliver and implement this plan. We had a discussions about the secondary fracture, remains a very key priority for us, but bone health assessments, primary care, primary assessment, prevention, everything is included in this, but not at a cost of things which is very easy to capture. So get the low-hanging fruit first and make sure we continue to deliver on the secondary fracture prevention first. Now, these are the high impact with the Welsh value measures, that how we can look into the accurate diagnosis, optimizing intervention, and supportive treatment first, before going to the prevention and the long-term care or end of life. And that's again based on the FLSDP principles, that this is what we are setting as for all health boards, that how we know we are effective and we're delivering. That's what we have to do. And I'd like to conclude by saying that our collective measure should be that first fracture be the last. And implementation of FLS is the single most important thing that we can be done to directly improve the patient care and reduce spiraling fracture-related healthcare costs to us. Care closer to home remains the ethos in Wales, and we will continue to practice, and we're working very closely in partnership with Frailty and community team. And I'd like to acknowledge all my colleagues, particularly patients and ROS team for their support. Thank you.